I'm going to be talking, along with Raffaele, for about the next hour about some new non-invasive screening options in terms of identifying expiratory flow limitation. And let's see if this works. No, it doesn't. Oh, well, never mind. Oh, jolly good. Let's try that. Yes, that works. And what we're going to cover, I hope, in this time is a number of topics. To try and understand something about the physiology behind expiratory flow limitation, how you can identify this in patients who you might see, what it means clinically, and we're going to tell you about some interesting new developments that are still kind of ongoing, but we think are potentially important in terms of the implications of expiratory flow limitation for ventilatory support. Hidden within this talk is also the belief that Raffaele and I both share that respiratory physiology is still important and that we neglect it at our peril because we can learn much which is of value by understanding how the lungs work. So that's the end of that commercial. Let's think a little bit about respiratory physiology. This is an audience that at least has some sympathy, I hope, to the idea that understanding how breathing works is relevant. But crucially, what most breathing's about in most creatures is to enable gas exchange. And we're all familiar with single-celled organisms like this amoeba, where gas exchange is not a problem. I'm fairly sure that flow limitation is not a problem for your average amoeba. If I'm wrong, correct me. But gas gets in and out of this organism by simple diffusion. When you get to bigger multicellular structures like this cheery goldfish, you need a circulatory system to move oxygen to the tissues, and you need a way of getting oxygen from the ambient environment into that circulatory system, which of course is why fish have gills and why they push water across it. A simple mechanical pump. When you get to somebody running on a beach looking very athletic, I should tell you this is not a picture of me in case anybody was getting confused. But when you're really reaching peak ventilation, you need to have a really good coordinated system for moving air in and out of the lungs. And basically, a lot of that is being moved by bulk flow of air along the airways, and then gas exchange is occurring in the periphery of the lung. You're uploading oxygen and from the room air into the blood, and you're downloading CO2, which you then expel. And a failure to expel that properly is going to lead to accumulation of CO2 in the body. They knew this before I was born, and I guess that means before anybody in this room was born. And we are familiar with the problems this creates, because you don't have to be a genius to see that there's a lot of gas here and a small aperture here. Of course, if you're evolvible, you go and count all those airways, and you produce beautiful graphs like this, which shows the cross-sectional area of the airways versus the airway generation, and it's very clear that the cross-sectional area here is great, and it's low here. That means that resistance in the periphery is low, but it is relatively high centrally. And it's that central choking, if you will, of resistance, if you want to expel air quickly, that's the basis of flow limitation that we're going to be talking about this lunchtime. So how much can you breathe out in a normal person? Well, the simple answer is it depends how much air is there to begin with. If you take a small breath in, you're not going to get so much out again. But if you take a big breath to total lung capacity, other factors will determine how much air you can get out. One of those factors is the driving pressure, which is a combination of lung and chest wall recoil pressures and, of course, expiratory muscle activity. We won't get into the nitty-gritty, that's a general phrase here, but we can say that if you make a lot of pressure, you get a very positive pleural pressure, that will help drive the air towards the airway opening. It will, of course, also depend on the resistance to flow. And that's very much, as we all know, dependent upon the radius of the airway, and the radius basically gets smaller in total as you get closer to the mouth. The radius is also determined by lung volume. If you're closer to FRC or residual volume, your airways are narrower than they are when you're at total lung capacity. So there's a dynamic effect occurring there, which actually has complicated understanding expiratory flow limitation because you have to take account of it. And one thing we tend not to remember, as I'll show you why this is important in a moment, is that the stiffness of the airway wall at the relevant generation of airway is also relevant. If you're looking at the very periphery of the lung, peripheral airways, there isn't very little to hold the airways open other than radial traction forces. More centrally, we know you have cartilaginous tissues and other tissues which help support the airway itself. Now, in everyday life, what do we mean by flow limitation? I would argue you're all very familiar with the problems of flow limitation. This is a picture of traffic in an underdeveloped country that I live in, where it's perfectly easy to go up and down the motorway along the N road because there's really no obstruction. And if you are this wagon or this car, you can press on your accelerator and you will go faster along that road because there's no obstruction. This, sadly, is more like the view from my window. And this is what British roads really look like. They're completely choked with traffic. And they are choked with traffic which is not moving very much because although the road's diameter is the same, the number of cars trying to go down it is too great. And no matter how many cars join this traffic jam, they will not move more freely through the holdup. That is flow limitation. And what applies to motor vehicles applies to gas particles as well in just the same way. A classical sort of diagram is this schematic one, where here you've got the alveolar component, here you've got the airways, and you reach a crucial point during expiration where pressure is being applied externally, but because of friction and related pressure losses as you breathe out, you reach a stage where the pressure inside the airway is at or even falls fractionally below the pressure outside. And if the airway wall is not stiff enough, that's what I meant by airway stiffness, you get a narrowing. And no matter how much effort you make, you're not going to get more air through that point. If you look at it here, the alveolar pressure initially is going to be able to drive flow, but then because the pressure falls off, you reach this critical point when suddenly, no matter how much effort you make, no more pressure, no more flow leaves the lungs. That's the mechanics of flow limitation. This is the so-called waterfall concept, where after this point, no more air cannot leave the lungs more quickly. And it's a really important thing that we've known about for a long time. This is the sort of thing that makes people groan inwardly. It reminds them of life as an early medical student. It's an iso-volume, remember correcting for that volume effect, pressure-flow relationship. And it's not really very complicated. As the pleural pressure becomes more negative, you get an inspiratory flow, and the more negative it becomes, the faster the flow goes, the greater the inspiratory flow. If you're breathing out, you get to a point where the pleural pressure becomes positive, and then no matter how much effort you make here, the flow doesn't increase. In fact, it actually decreases a little. And that is what we mean by flow limitation. And we've known for a long time, certainly back to the 1960s, that this underpins the behaviour, the mechanical behaviour of healthy and diseased lungs. And that's what the great Bob Hyatt showed in this paper that was published in the Old American Review of Respiratory Disease over 55 years ago, where he described the behaviour of the healthy and the diseased respiratory system, and he explained the relationships between pressure, flow and volume, just as I've shown you in that diagram. One of the great things that Hyatt created was our understanding of the maximum inspiratory and expiratory flow volume loops. That there were conditions where if you were breathing hard enough, flow would be limited. That's why this is such a reproducible thing during expiration, but not necessarily inspiration. Normally, when you're breathing quietly, the relationship between flow and volume is shown here, and there's lots and lots of expiratory flow reserve. Even when you're like that guy running on the beach, there is still a lot of expiratory flow reserve. That chap is going to be slowed down because of the inability of his circulation to keep oxygen going to his potentially fatiguing and exercising muscles, not because of ventilatory limitations. How different then is the situation with somebody with obstructive lung disease, where a combination of emphysema and small airways disease reduces the elastic recoil, increases peripheral resistance, and then the maximum expiratory flow volume loop looks like this. And here we've got our little tidal breathing loop, which is now sitting very close to that loop. And when you exercise this time, you can't increase expiratory flow. And so basically you have the equivalent of breath stacking within the lungs. And that's pretty well how we realised this was what was going on, back to the days when PEEP-I was first described. And end expiratory lung volume rises on exercise in order to increase expiratory flow. And we understand that that change in end expiratory lung volume is crucially related to symptoms in COPD and to exercise performance. And it does tie up pretty closely with the presence of tidal expiratory flow limitation. It's not necessarily universally the case. There are other mechanisms that can apply, but in the great majority of people, there's a close relationship between dynamic hyperinflation and tidal expiratory flow limitation. We know if you look at what happens in COPD, and this is really, we're back to pleural pressure volume relationships here, you're starting at a higher volume, you hyperinflate, you're doing more work when you do that. And even under resting conditions, you can compute the impact on work of breathing in terms of PEEP-I and dynamic hyperinflation. And you can see that the COPD patient does an awful lot more work of breathing during inspiration than a healthy, normal subject. So PEEP-I and dynamic hyperinflation both make a contribution to that story, and they are intimately related. So I've briefly sketched out why I, for one, believe that tidal expiratory flow limitation is important. But we need usable ways of detecting this thing, because until recently, we haven't thought in terms of tidal breathing measurements. We've only thought in terms of measuring things when you make a big effort to breathe in or breathe out. And we've kind of inferred what that will mean for patients. Well, one reason we've not gone down that route is because it's been really difficult. Classically, back in the era of Hyatt, you were able to measure or determine whether a breath was flow limited because you measured the intrathoracic pressures with an esophageal balloon and could measure the pleural pressure, and indeed correct for resistive pressure flow losses. You could take Hyatt's ideas of what happens with the maximal and the tidal loop, and if you could get a good maximal loop, you might be able to put the tidal volume loop from an inspiratory capacity maneuver somewhere within it. But there is breath-to-breath variation, and it can be very easy to misjudge that. And moreover, there are issues with gas compression, so you really need a body box to do that. A very elegant solution from the Belgian group is simply to press on the abdomen when somebody's breathing out and see if you can increase expiratory flow. And astonishingly, that works. And I'll show you an example in a moment. But the difficulty is timing the pressure and coping with what happens if somebody actually decides to contract their abdominal muscles at the same time that you press on their abdomen. A very elegant mechanical method of testing for expiratory flow limitation during tidal breathing was developed by my old chief, Milik Emily, where they timed an acute expiratory suction to see whether you could increase flow at the mouth if you applied a big negative pressure. I'll show you an example of that too. But all of these methods have problems. Some of them, like balloons, are invasive. There are gas compression artifacts that I mentioned in terms of the flow volume loop, and difficulties in knowing where the tidal loop goes. And one other factor that we have to be cognizant of when thinking about this measurement is the posture in which it's measured. This is the abdominal compression method. Here's somebody breathing, that's flow, this is volume down here. And here is expiratory flow going down, and when they press, expiratory flow increases. That's what happens when the person is seated. When they lie down, the same person, expiratory flow has very little impact. You can produce a sudden increase a sudden transient increase in flow, but for most of the breath, there is no increase in expiratory flow. And position, largely related to changes in functional residual capacity, will make a big difference as to whether somebody is tidally flow limited or not. This is the negative expiratory pressure method. Here the person is breathing along quietly, then you add a negative pressure and you get an increase in flow. So you have a nice simple flow limited or not approach to that breath. This is one which is at least partially flow limited, as you can see here. The difficulty with this has been trying to make it numerically sound and make it easy to repeat measurements in different people. However, there are alternative methods of doing this which overcome some of those problems, and I'm going to hand over to my good friend and colleague Raffaella Dell'Acca to tell you about those.
So thank you, Peter. So as Peter told you, the most important effect of the presence of tidal expiratory flow limitation is a huge difference of respiratory mechanics between inspiration and expiration. Therefore, methods for detecting the development of expiratory flow limitation should focus in assessing lung mechanics between these two different conditions, inspiration and expiration. If we make one step back and think about what is studying lung mechanics, we can identify lung mechanics as the relationship between the forces that are acting on the system and the movement that these forces produces. In terms of respiratory mechanics, the forces are the pressures that are acting on the respiratory system, and the displacement are the flows that are produced by the system. If you want to study mechanics, we need to study the relationship between these two variables. For measuring flow, this is not a big deal. We can use a pneumotachograph connected to the airway opening. We can use a mask, a mouthpiece, whatever, and then we can easily record the flow. The problem is when we want to measure the pressure, because the pressure is generated by the respiratory muscles, and so it is generated within the body of the patient. The only way we have to make a proper characterization of this pressure is by using the esophageal balloon technique. So we need to place an esophageal balloon in the esophagus in order to probe the pressure that the chest wall is applying to the lung. Unfortunately, this is an invasive technique and is also a little bit difficult to handle, so you need a little of expertise in order to place the balloon and to analyze the graph and the relationship that you get from this. It would be much easier if we were able to apply the pressure from the outside, because if we apply the pressure from the outside, now we can measure the pressure, we can measure the flow, and we can characterize the mechanical properties of the respiratory system. So this is nice. The problem is that the pressure that is driving this flow is still due to the contribution of both pressure generators, because the pressure generated externally adds on the pressure generated by the respiratory muscles. So we need to find a way to to switch the respiratory muscles off. Study in respiratory mechanics done during invasive mechanical ventilation were done by using paralysis. So it was possible to measure relatively easily the compliance and resistance of the respiratory system. An alternative approach was proposed by Arthur Dubois many years ago. We are talking about the first publication on this technology is in 1956. And interestingly, Dubois is the same researcher that introduced the body box technology for measuring the TGV. So, you know, TGV is now used everywhere, force oscillation not yet. So there were much more problems to be understood and solved before being able to apply this technology clinically. But the idea is extremely simple. We study the mechanical property of the system, respiratory system, by applying a small amplitude at high frequency pressure oscillation to the airway opening. And then we relate the pressure that we apply to the oscillatory flow which is produced. How can we do this? The typical approach is by using loudspeakers, the ones that are used to create noise, especially in the cars, for creating the very low frequency sounds, so it's a relatively big loudspeaker. Loudspeaker is producing these force oscillations that are applied to the airway opening simply by a mouthpiece, and then we measure the flow and the pressure, and we can record the frequency response of the respiratory system. We need to add some other tools, because we need to allow the patient to breathe also. So there are some other equipment needed for these purposes, but in principle, the approach is extremely simple. This is an example of a pressure and flow time course that we recorded on a patient during quiet breathing. You can clearly identify the high frequency oscillation applied by the loudspeaker that is moving very, very fast, and the slow moving pressure and flow signals due to the respiratory activity of the patient, so the quiet breathing of the patient. If we keep the frequency high enough, then we can easily split the two contributions in the same tracing by using digital filter. So we can simply extract the fast-moving component and consider it as isolated from the slow-moving component. So this is the key of the force oscillation technique, the use of a high frequency that allows to exclude, to cancel the contribution of the slow-moving respiratory muscles. Now we can compute the relationship between the externally applied pressure and the flow and measure lung mechanics even if the patient is breathing spontaneously. So this technology is a little bit complicated from a mathematical point of view, but it provides two important information. First of all, the number that force oscillation provides is called impedance, usually is defined as Z, and is a number that is actually made of other two numbers. One is the respiratory system resistance that accounts for the resistance for the central airways, mostly. And the second is called reactance. Reactance is a number, it's a little bit strange, it's a number that collects two different contributions. One is due to the inertia of the system, and the other, that is the most important for us, is related to the compliance of the respiratory system. So what we need to remember from this equation is that the reactance brings information about the compliance of the respiratory system. And now we will see why this is important. Force oscillation historically has been applied since many years, but most of the studies were focusing the application of force oscillation by using an approach based on putting together several frequencies, applying frequencies for 40 seconds, 1 minute, and then making the assessment of the resistance and the reactance as a function of the frequency that was applied. So this is called the spectra of the respiratory system. There is another approach that is for us much more interesting. That is, instead of using several frequencies and applying the frequency for a long time, we apply only one frequency, but we apply this continuously, and we do the analysis on a very, very short time. This produces, as a result, the time course of the resistance and the reactance. So we can see how the resistance and reactance changes within a single breath. We can measure resistance during inspiration and distinguish this value compared to what we measure during expiration. So now let's get back to the waterfall concept to understand how force oscillation can help us in detecting expiratory flow limitation. As Peter showed you, the waterfall concept is a nice way to express the concept of expiratory flow limitation. This is the airway opening pressure, and when a patient is flow limited, if you change airway opening pressure, this change cannot affect the amount of flow that is going through the system. Okay? So if we apply an oscillatory pressure at the airway opening, what we do is we change slightly the height of this layer here. But this is not enough to affect the amount of flow that is going through the system. So the force oscillation cannot climb up this waterfall. They are not salmon-like. So they stop when they find the critical pressure. Let's see this in a better way. Here you have a simple model of the respiratory system. We have the airways and we have the alveoli. If you are a patient without expiratory flow limitation during the expiratory phase, when we apply the oscillatory pressure, the pressure will travel through the airways and probe the mechanical properties of the full lung. But when we have a choked airways here, the flow in this point is independent of the driving pressure. So when we apply the force oscillations, this force oscillation cannot cross the choke point. So even if there is an expiratory flow, so this is not closed, it's open, force oscillation cannot go through this point. This means that force oscillation will probe two very different systems between inspiration and expiration. This is a simple model of the lung. When the patient is in the inspiratory phase, what force oscillation will probe the mechanical properties of the full lung. But when we develop choke points during the expiratory phase, now force oscillation will be able to probe only the amount of lung that they can reach, so just the central airways. What is the most important difference between these two lungs? Is that the resistance, as you know, is mostly located in the central airways, but the elastance is in the alveoli. So we won't see a big difference in the resistance, but we are expecting a big difference in the reactance, so in the compliance that is measured by the force oscillations. And if, as you remember, actually, you can see it, the reactance is related to the compliance by this formula. It means that if we have a reduction of compliance, we will have an increase of the negative contribution to the reactance. The reactance becomes more negative because the system is much stiffer. Here you can see an example of a time course of resistance and reactance in a patient that was flow limited during tidal breathing. As you can see, during the inspiratory phase, we have a reactance that is in a range of the normal values for COPD, -2. But as soon as the patient starts to exhale, you see that there is a huge negative swing of the reactance. This is because now force oscillation can no longer reach the alveoli, and so we measure only the mechanical properties of the central airways. In order to characterize and to create a quantitative index able to identify automatically the presence of tidal EFL, we introduced several indices. We tested several of those. The ones that show to be more effective is the one that we call delta XRS. That is just the difference between the value of the reactance from inspiratory to the expiratory phase. So the inspiratory reactance and expiratory reactance, this difference is the delta X. If there is no tidal EFL, we are expecting a value of delta X close to 0. If there is EFL, these numbers start to increase. We did several validation studies to be sure that this technology was actually working in all different, in many different patient types. And we use as a gold standard the esophageal balloon technique. And we found that compared to the esophageal balloon technique, force oscillation provided 100% sensitivity and specificity simply by applying a threshold that is like a magic number. If you consider the delta X, if delta X is greater than this number, the patient is flow limited, otherwise is not. So this technology was in very good agreement with Mide Wittenberger. Then we developed also another study in collaboration with Peter Calvary and Nick Couloris. Nick Couloris with Milic. Emily was the inventor of the negative expiratory pressure technique. So we compared the two approaches and we found that there is a very, very good agreement between the two. This is the classification of patients given by the NEP score, so with the negative expiratory pressure technique. This is the delta X, and as you can see, the two techniques classify similarly patients with expiratory flow limitation and without expiratory flow limitation.
Thank you, Raffaele. Now, we've now got a technique which, if you've seen, has an excellent theoretical basis and is practical, where you can measure not just one, but multiple breaths, and you can do it simply and say whether or not this magic entity, expiratory flow limitation, is present during tidal breathing. So a reasonable question to ask is, how commonly do we see it? We took data here from part of the ECLIPSE study, where we were able to use the data from ECLIPSE and analyse delta XRS in just the way that Raffaele has outlined. This is some data from Bernd Daly, who was a PhD student who I worked with in Bergen. And you can see in elderly normal people, important to look in elderly people because they're the people where, if this is going to occur, it will do, because they're the people who've lost some elastic recoil, with one exception. I don't know what happened to this person, but with one exception, the delta XRS was within our normal range. They weren't flow limited. What about COPD patients? Well, we've seen previously that there's a range of possible responses. In the bottom panel, says he, peering carefully, you've got somebody, and here's multiple breaths recorded, and here's the delta XRS at the bottom of this. You see somebody whose values are below that critical threshold. In the middle, in the top panel, you see somebody whose values are consistently above that critical threshold. And in the middle, you've got somebody where, rather like the three bears here, somebody who's variable, which does vary from day to day and breath to breath. And what that taught us was that there's a difference, certainly among our COPD patients, between a tidally flow-limited breath and a tidally flow-limited patient. And we saw this when we looked at the Norwegian data, in that some people had a lot of breaths that were flow limited, and others had breaths, had only a few breaths that were flow limited. And so we ended up producing kind of operational cut points of people who were variably flow limited, as well as people who were truly flow limited with every breath. Now, these measurements have been all made seated. And I think had we made these measurements with the people supine, we would have seen a different story, because I showed you earlier on, posture is really important. So this is the most conservative estimate that we can come up with. But we do have data that went over 3 years, and broadly speaking, there were a percentage of people who were below our threshold and who were consistently not flow limited. There were a lot of people above the 0.28 who were consistently flow limited, and some people in the middle. So it's not absolutely fixed. People will vary from day to day, and that's important, because you may, if you're going to introduce a treatment, you may want to do this in a way that is responsive to the individual, but broadly our general categorization works, and flow limitation is pretty common in COPD. And we related this in a paper in the ERJ, really to the FEV1, our most familiar number. Here's basically histogram plots of our population. We had almost 400 people. It's no surprise that the very severely obstructed were all really pretty flow limited as a group, and it's no surprise that the less obstructed were hardly flow limited. But actually there are some people out here with an FEV1 of 60 or 70, 50 or 60% predicted, where tidal flow limitation was still present. So does it matter? What are the clinical implications of all of this? Should it really bother us? Well, to some extent, I think it should. That basically, the big discriminant factor between our flow-limited and non-flow limited people was not their FEV1, and this is data actually using the NEP technique, so it's true with that technique as well. The big discriminant factor was the fact that if you were flow-limited, your inspiratory capacity was lower than if you were not flow limited. And unsurprisingly, because of that fact, you had a worse exercise performance than the people who were not flow limited. This is our maximum oxygen consumption at peak exercise. So exercise performance, as you would expect, is related to abnormal lung mechanics. And so is the patient's reports of breathlessness. We're back to our Norwegian population, categorised using the method Raffaele outlined. And even when we allowed them and grouped them into people who had similar FEV1s, goal group 2, 3, and 4, you could see that particularly the flow-limited people had higher degrees of breathlessness reported on the MRC breathlessness scale. So you add in to what the information you get from an FEV1, a bit more information from knowing if these people had tidal flow limitation. Now, we were a bit disappointed when we saw these data because I'd just shown you the peak exercise on a cycle ergometer. We were expecting to see something similar with a 6-minute walking distance, but a lot of things determining how far you walk in 6 minutes, and this relationship was really no different from that we saw with the FEV1 in these Norwegians. What we did see, though, was that we looked at what happened over time, is that the people who were tidally flow limited at the start of our study were the people whose walking distance declined over time and declined to a point where it's clinically important. So maybe what the flow limitation was telling us was not necessarily how far they walked to begin with, but what was going to happen to them in future. You'd reached a worse stage in the natural history of your disease if you're in this group compared with being over here. Now, some years ago, we used oscillatory mechanics, not partitioned as Raphael has described, to try and identify exacerbations of COPD. And one of the things that was striking to us in Nicky Stevenson's paper in the Blue Journal 12 years ago now, was that when people recovered from their exacerbations, their reactance values, this is whole breath reactance values, improved. And that was really very relevant and certainly as good a sign of improvement and reduced breathlessness as changes in the FEV1. We saw in our Norwegian patients that the people who had exacerbations were more likely to exacerbate if they had tidal flow limitation than if they did not, and were more likely to be hospitalized if they had tidal flow limitation than if they did not. And perhaps unsurprisingly, well, it was that there's a relationship between mortality and tidal flow limitation. Now, it turns out if you've got a low FEV1, because almost all of these people were tidally flow limited, you don't get a lot of extra additional mortality information. But if you look at the people with rather better FEV1s and split them into people who did and did not have tidal flow limitation, you see that the people who had preserved lung function but flow limitation over the 5-year follow-up of this study were more likely to die than those who did not have tidal flow limitation and a similar FEV1. So I think we've now got a prognostic variable, at least in patients with less advanced COPD, as well as a variable that tells us something about people's immediate exercise performance and symptomatology. Now, naturally, we'd like to treat things. That's what we want to do as doctors. And are there any things that we can do? Well, rehabilitation is a good thing. My friend Barry Makes at the back of the audience, and he would hit me if I said anything else, but he knows perfectly well, and we both agree, that pulmonary rehabilitation is a very good thing. But we're equally sure that it doesn't have any effect on lung mechanics. So by all means, have your patients rehabilitated, but don't expect it to change the degree of tidal flow limitation. Because this is a mechanical problem, you might be able to change it if you gave a bronchodilator drug. Or you might have to do something different in the way of other mechanical supportive approaches that could be relevant in other specific circumstances. I'm going to say a word about this before handing over to Raffaele to tell you how we've approached that problem. This is back to the old NEP data. It's a paper Justine Hadcroft and I wrote before we developed the FOT system. And it was one of the first to look at bronchodilators and expiratory flow limitation in COPD. And we had groups of people who showed this sort of pattern. If they were non-flow limited, they got improved lung volumes and generally felt better after a bronchodilator. If they were flow limited, we saw some improvement in the lung volumes, but it didn't change the degree of expiratory flow limitation. So what tended to happen is that they'd operate at a lower lung volume, but because of the severity of the disease, they still tended to be flow limited. Raffaele and I did another study using the FOT approach, looking at what happened with bronchodilators to define flow limitation. And needless to say, in the flow limited and non-flow limited, we saw improvements in lung function and we saw falls in residual volume. And that was exactly what lots of other people have shown in COPD with bronchodilator drugs. When we looked at the oscillatory mechanics parameters, then you did see changes, particularly in expiratory reactants. But in terms of delta XRS, yes, we saw some improvements in this study using this more sensitive approach. And some people, actually, we did change their flow limitation status, but it was very much a minority. we hadn't had a big impact with our bronchodilators on whether they were flow limited. Now, all of the patients we're talking about will be receiving bronchodilator drugs, so this is a slightly academic argument. But what I'm showing you is that you can't abolish this particular physical problem, even though you can get other improvements. It still remains a limiting condition for these severely affected patients. Now let's look about what would happen in patients who need ventilatory support and how we might be able to do something for them. Raffaele.
So having the availability of a technology that can measure the presence of EFL breath by breath and in continuous way, we started to think about the possibility to use this variable in order to optimize NIV in patients with COPD. So we started with the first validation study to evaluate if the same technology was accurate enough when applied in a totally different circumstance. So we are studying now patients in which we are applying force oscillation through the nose, and we know that this is the resistance of this pathway is much greater, and we are doing this measurement while patients were receiving CPAP. In order to produce force oscillation, we combined our loudspeaker with the CPAP system and used the same setup for measuring flow and pressure. Here you can see some recordings, some tracings from a representative patients in which we record some breaths at CPAP of 0 centimeters of water, 4, 8, and 12 centimeters of water. So we increased the CPAP in stepwise by 4 centimeters of water each time. Here you can see several variables. There is volume, there is the pressure, and here you can see force oscillation data, resistance, and reactance. From reactance, we compute the delta X, and here you see the reference line that is the threshold for expiratory flow limitation. So as you can see, this patient was flow limited in all breath considered here when he was receiving a CPAP of 0 centimeters of water. But as soon as we increased the CPAP to 4, 8, and 12, we were able to abolish in a very consistent way the presence of expiratory flow limitation. So the goal of the study was to make a validation of the technique. So we did the same analysis by measuring sensitivity and specificity. And here the imposing of the two curves that we got, one with this study, so nasal CPAP, and the previous study that was done by measuring with force oscillation at the mouth with the mouthpiece. And you can see that there is a beautiful overlap of the two graphs. So the same threshold works, we got similar sensitivity and specificity. In this study, we were also testing what happens when changing posture. So patients were studied both in the seated and in supine position. And this is our representative patient. As you can see, that delta X was above the threshold for expiratory flow limitation at 0 centimeters of water when the patient was seated position. As soon as we increased the pressure to 4, this patient was no longer flow limited, and this was the same at 8 and 12 centimeters of water. But the same patient, when he moved to the supine position, because of the different configuration of the chest wall with the abdominal contents that is now pushing up the diaphragm, therefore reducing the end expiratory lung volume, resulted in much greater delta X with 0 centimeters of water, of CPAP. And now going to 4 centimeters of water was not enough to abolish EFL, and the same patient was needing much greater pressures in order to abolish EFL in the supine condition. So starting from this data, we thought that integrating the technology in a ventilator might be an ideal approach for self-tailoring on the EPAP. So this is the classical schema that is used to refer to closed-loop control in mechanical ventilation. We have the patient, the ventilator is acting on the patient, we measure some variables, and thanks to these variables, we adjust automatically some parameters of the ventilator. So we tried to implement one possible version of this, in which the measure was the measurement of the presence of tidal EFL with force oscillation technique, and the intervention was the adjustment of the expiratory pressure, the EPAP, in order to abolish EFL. We started collaboration with Philips Respironics in order to develop a prototype, and here you can see the prototype functioning, in which you have the airway opening pressure and the delta X measured by the ventilator on a representative patient for some time. So we started applying the device to a patient using a very low level of EPAP. You can see this was 6 centimeters of water. Patient was breathing, ventilated, but delta X was quite high, suggesting that the patient was still having tidal expiratory flow limitation. So the ventilator automatically adjusted slowly, time by time, breath by breath, the EPAP in order to reach the value in which delta X was now around the threshold. So finding the right pressure that was able to abolish EFL in the patient. So we started using this device, and in collaboration with Michele Vitacca in Italy, we ran a first study in trying to see which was the pressure needed to abolish expiratory flow limitation in COPD patients that were receiving the NIV, and to see the impact of changing posture on this value. And this is these are results that were extremely interesting for us. So seated position, the device was able to identify a pressure able to abolish flow limitation that was in average relatively low. Many patients were not flow limited in seated position, so 19 patients were not flow limited, so only 27% of the patients that we studied were flow limited in a seated position. But as soon as we move the patient to the supine position, the same patients, as you can see, change dramatically the amount of pressure needed to abolish EFL. So we had an increase in very variable value of EPAP needed to abolish EFL in these patients, but also we have much less patients that were not flow limited in the supine position. So the prevalence of tidal EFL was now increased to 65%. Here you can see the relationship between the EPAP that was automatically identified by the machine, the tailored EPAP, with the prescribed EPAP. So this was the value that was prescribed by the physician. All patients were they were NIV users. And as you can see, the average value is very, very similar. They were about 7.4, 7.3 centimeters of water, but the distribution is very, very different. So it suggests that the average pressure that the physicians identify for this group of patients was correct for the mechanical condition, but on individual basis, this is still a lot of variability. Is the presence of the amount of pressure needed to abolish EFL in supine position related to anthropometric or spirometric variables? Well, interestingly, there is no correlation with spirometric variables, not at all. There is a correlation as expected with the BMI, but is not as strong as we were expecting. So it's a significant but relatively weak correlation, suggesting that the pressure that is needed to abolish EFL is an independent feature of COPD, so it should be considered in addition to the other known variables. Then we started a nice physiologic study in collaboration with Nicholas Hart group de St. Thomas with the USIC and Swap Mandal. We collected data in COPD patients that were ventilated with esophageal balloon, gastric balloon, electromyographic assessment of the diaphragm and so on. So it was like a church instead of a protocol. But it was extremely interesting for us to better understand what was happening at the physiology in these patients. And the protocol was, first of all, we let the ventilator identify the optimal value of a CPAP, as you can see in this period, for a while. And then once this value has been identified, we explore the pressure around this value in the stepwise decrease in order to understand how different physiological parameters were changing when we were adopting pressure that were a little bit higher or lower to the optimal mechanical pressure. And what we found is that several variables actually suggest that the pressure that was applied by the system was actually the minimum pressure able to minimize PDI, EMG, and other variables indicating that can be used to have insight on the work of breathing. Last preliminary data I would like to share with you are from a study we are doing also with Michele Vitacca in Italy. The idea was to bring the device, to use the device on a long time scale, the overnight, with patients with COPD. So we did this randomized crossover trial, 2 different nights at the hospital with full PSG done. In one night, the patient was receiving the prescribed fixed parameters for the use, the ventilation settings that they were used to receive. And in the other night, we were using the automatic setting system. This is an ongoing study. The data I'm showing you refers to 15 patients. So this is an example of 190 in a representative patients. Here you can see the transcutaneous CO2 measured, and this is the pressure measured at the ventilator. The setting was constant setting, so you can see the same pressure applying overnight. The CO2 increased and fluctuates a lot during the night. The same patient, this is the same patient during the night in which he was receiving the automatic titrated pressure. As you can see now, the pressure is very variable. It's adjusting continuously, changing from higher and lower values. As you can see, with some relatively fast changes and some more long-term trend changes with time. But the results of this different pattern of application of pressure was a significant improvement in CO2 that was much lower for all the night. And why are we observing such a variable condition in a short time? Well, we are still processing the PSG data to see what happens with the different sleep stages, but for sure, we already identified the change in posture has a huge impact in the pressure that you should give to a patient in order to abolish tidal EFL. Here you can see the body position, left side, supine, and the right side, and how the ventilator reacted to this change in posture over the night in order to adjust the pressure and to optimize the mechanical condition of the lung on the patient time by time. Results, preliminary results, we analyzed first of all the CO2, and we expressed this data from the transcutaneous CO2 as the percentage of the night in which the patient has the CO2 greater than 45, 50, and 55 millimeters of mercury. Here you can see that with the prescribed EPAP, most of the patients spend almost all the whole night with values that were above 45. With the automatic EPAP setting, this value reduced significantly, about 0.6, and this difference is also present at 50, while and 55 is no longer significant, but it's still there. Moreover, we measured also, we identified also reduced number of ineffective efforts. They were reduced by approximately 25%. And also we found that the application of this technology did not affect the sleep efficacy. Leave Peter the last bit.
And as usual, I get the last word. So you've heard what we've been trying to say about what we think are some interesting new data. What do I think we can conclude? Well, I hope we've convinced you by this stage that expiratory flow limitation on forced expiration is a normal feature of human life. But being flow limited during quiet breathing is not and has consequences. It promotes dynamic hyperinflation, and that leads to more work of breathing during inspiration. It leads to exercise limitation, inevitably breathlessness during daily activities. It's a marker of people who get more exacerbations, and for some at least, a marker of an increased risk of mortality. For the first time now, we can reliably detect in a non-invasive and automated way the presence of expiratory flow limitation. This is no longer something which is of interest to rather geeky physiologists in darkened laboratories who talk about this stuff in muttered voices. It's now, I think, really getting ready for prime time. Crucially, and both Raffaele and I have stressed this, it's commoner when you're lying supine than seated. So that's really of relevance to an audience like this that deals with a lot of recumbent or semi-recumbent COPD patients. We believe that adjusting a ventilator to minimize tidal expiratory flow in a dynamic fashion can produce physiological improvements, some of which look to be very important, though clearly this is work in progress and we'll keep you updated. Most importantly, I think that new measurements like these can change the way in which we manage COPD, and that can only be a good thing. To conclude with, here's a picture of some of Raffaele's fellows. I draw your attention to two things here. This is a very happy group of people, and they are young. So maybe physiology has a future after all. Thank you.
This is a tough act to follow, these two esteemed gentlemen, certainly. And they give me a very short amount of time to give a short presentation. So this is all well and fine what they went on, and it's exciting opportunity. But you need a reason to believe. What is the confidence that we could do this reliably in a ventilatory solution? All right? Uh-oh. So this is a diagram that you were familiar with. This over a little bit. All right? And this is rather complex and not really suitable for putting in a ventilator. You have a speaker here and somewhere, okay? And you know, you have a vacuum source and sort of a Rube Goldberg type of contraption, and you have to put that into a ventilator. One of the problems is you need to be able to generate these forced oscillation reliably at 5 hertz, and you need, they can't be distorted, and you need good coherence with these oscillations. So one of the benefits of this simple mathematic algorithm, if you will, is that it looks comparatively at the reactance during inspiration and expiration. And for the most part, this can benefit the development. So if you have an error in your measurement that occurs during inspiration, and if it occurs equally in expiration, then all is good. They cancel each other out. However, there's a possibility of having nonlinearities in the system where this doesn't actually occur. As was explained earlier, impedance is a phasal relationship, and this is a simplified, they went through the more difficult analysis, is a phasal relationship between the flow and pressure. And this is very sensitive when you incorporate it into any device. You can easily get these nonlinearities to occur. And one example, if you looked at different ventilators, which I did, you can see that this is a curve of the impedance versus flow, not the flow versus pressure. This is impedance. So if you have a fixed load, a fixed impedance on the test bench, for instance, you would expect this to be flat. And certainly at the higher flows, that represents inspiration. And although this curve doesn't go quite towards expiration, I think you can get the idea that if you took a measurement during inspiration, it's going to be elevated. And if you took it during expiration, so it actually amplifies our error. So this works against us. So the idea was to develop a reliable linear solution. So after quite some time, and dozens of iterations, much like Edison inventing a light bulb, I came up with a secret sauce which the security police sort of kind of blurred out so you couldn't detect every little detail here in the solution, but there is some secret sauce in there. And what that does, their result gives us, as you can see, very linear, under a fixed load, impedance with flow. And that's highly reproducible and reliable. And as a benefit, I got bonus points because I also have a very linear, the solution provides a very linear solution between pressure and flow, nice laminar flow. And I don't know if you can make out the detail, but there's a dotted line there, which is a high-end Fleisch pneumatic, costs probably $1,000, and this is a relatively inexpensive solution. So it's linear with against flow, both pressure and impedance. But there were some other problems that are presented. That's all within the ventilator, but we're measuring a patient out here, and you have some other measurements that you have to account for: the compliance of the tube, the intentional leak, and so on. So by doing numerous measurements, measuring pressure both in flow in the ventilator, outside the ventilator, and at the patient, and then in this particular case, the study we did with Dr. Calverley, they had this esophageal balloon and so on. This can be characterized by this mathematical circuit, which I won't go into, but you can characterize these, the tube and the whisper swivel leak in the mask, and make a correction for that. And you can do that reliably because it does follow this mathematical model. Here it is tested on the bench. This is another example of the type of bench testing that we had to do. Here are two bottles, so they represent different reactances. So you could rapidly switch between inspiration and expiration, and you should get a predictable delta XRS, the difference between these two compliances, and they also have some fixed linear resistors. So again, as Raffaele explained, these are Mead-Wittenberger curves, and the way those sensitivity and specificity graphs were determined is we literally went through thousands of breaths and manually scored them. You know, in this case, this is a non-flow limited breath, and this is an easy example of a flow limited breath, right? And then behind the scenes, we were blinded to what the delta XRS calculation, and this is just an example of what they might be. And when you do this type of analysis, you're able to come up with this type of graph. And there's two important things that you can note from this graph. One is this reproduces very well with the results from the speaker-based system. We are at 95%, and I think under perfect conditions you can get maybe 100%. But more importantly, you're able to develop a threshold. In this case, it's 2.8. And this works very well for us in the development of a solution in a ventilator. So in this case, again, much of this was previously explained, you have a threshold value, and you have a high delta XRS value. So as you increase your EPAP repeat pressure, it goes up, your delta XRS goes down, until it hits this threshold value. And then the ventilator knows to stop, all right? And just toggles around that threshold value. And here it is again. In this case, the patient was on pressure support, I believe of 6, and you can see both the EPAP and the IPAP move along. Delta X goes down, and when it hits that threshold value, it just sort of toggles up and down. So here's a sort of a case study I just wanted to throw in at the end of this presentation. One of the things that you find, and I won't read through, but you can read a little bit of her patient history. She's a COPD patient, gold stage 1, naive to COPD patient. And by now I've studied, as did Raffaele and Dr. Calverley, dozens, if not hundreds of patients. And there's certain characteristics. This patient is not your typical patient that you would expect to benefit or have expiratory flow limitation and need to be put on a ventilator. And here is her results. So her EPAP and her IPAP go up, right? And I believe her EPAP, let me take a better look, settled somewhere around 15 or so, and her delta XRS went down. Now, if I come to you and I tell you that this is a naive patient, gold stage 1, I put this patient in a supine position on a ventilator, and what happens? Naive to CPAP or bilevel, she fell asleep. Out of the dozens of patients that I've studied, and we've seen the EPAP in many cases go to 13, 14, 15, 17, naive, and they fall asleep, you would have thought I was crazy, right? So what happens if you put it on a healthy patient? So I had a volunteer somewhere in the audience, put it on them, and of course, the ventilator does nothing. Their pressure support and ventilation remains constant, as you would expect, as you would hope. There it is. So in conclusion, now I know everybody basically understood the presentations earlier, but there are probably a few that snuck in and got a free lunch and are wondering what the heck is all this about. So let me give you an analogy. And the analogy is for a diabetic, something that I think we could maybe relate to a little easier than a patient with expiratory flow limitation. So what is this that we're talking about? It's a diagnostic, it's a glucometer. So how do you know if a patient's diabetic? You have to be able to determine with some diagnostic in the case of a glucometer. Okay, that's all well and fine, but what's the therapy? Insulin in this example, right? That's all well and fine, but you have to be able to give them that insulin. What's the delivery system? A needle. So what do we have here? We have a system that's able to detect, deliver, and treat. Detect, deliver, and treat these patients. And we have, as you saw presented earlier, documented evidence that this all works. And I think that's in conclusion.
While they're getting to you, let me just ask a question. You showed how variable the pressure is needed to get rid of expiratory flow limitation on a given night. How variable do you think it is day to day? I mean, if somebody has no expiratory flow limitation on one day, are they likely to have it the next day? And how would that relate to the status of their COPD?
I think the answer, like many things in clinical medicine, is you play a probabilities game. We know from monitoring the healthy elderly in Norway that if you look at them over time, they don't they're not very likely to suddenly go from non-flow limited to flow limited. If you look at a COPD patient, we certainly got examples of people who were not flow limited on one measurement who would be flow limited on a measurement on another day. That contributed to some of that dense noise in the graphic I put up. So I think once you move into a situation where flow limitation is part of the problem, which it very much is in COPD, then you may need to capture a complete picture to measure things more than once. As I've stressed, it's positionally dependent, and also there is some day-to-day variability. To be quite honest, David, we don't know in enough people over a long enough period how big that is, but it must exist.
João Vink, Porto, Portugal. Thank you so much. Very exciting new technology. I wonder if you studied some patients with sleep apnea, how this technology responds to the upper airway obstruction. I wonder if in overlap patients that can cause some noise in the the titration phase. So could you expand a little bit on that?
I've not done that personally. I don't know if you have, Raffaele. Have you studied any people with sleep apnea, and what would be your theoretical prediction of the impact of an increase in inspiratory resistance and reactance with the onset of sleep?
So in this study, we decided to exclude patients with sleep apnea just to have a clean situation and to. We did some tests with this algorithm. This algorithm is not affected by sleep apnea. So for treating patients, which are quite common, having both syndrome, you need to have two algorithms working together. The advantage of this algorithm is that it's quite selective, so there should not be interference with other approaches that are commonly used to detect obstructive apnea and adjust pressure. Thank you.
I'll make a quick comment that Philips has an algorithm, obviously, for EPAP adjustments for upper airway. They now have an algorithm for lower airway dealing with expiratory flow. Those have not at this moment been combined, but will be, to where you can tie. And what you probably have to do in that circumstance would go to whichever's highest. If you need a higher pressure to keep the lower airway open, then you go to that, and the upper airway will obviously be open and vice versa. So that'll probably be the direction that it takes. Question over here.
Can I make a comment onto that as well, David? Because from the data that we've got, it's really important that we look at the people with upper airways and whether the upper airway is closing. But what you see from the data that we had, that ESIC did, that if you don't get the right EPAP, CPAP applied to the airway to abolish flow limitation, then the neural drive is up, the work of breathing is up. If you get to that point, that optimal point, you can drive will fall as well as work of breathing. The great thing about that, you can go a little bit the other side, so you can over-pressurize, and it doesn't have a negative impact on drive or work of breathing. And that's really important, because I think for some of these guys, it's going to be the control of the upper airway, which is going to be far greater than perhaps the lower airway. But I think we can be safe with it.
You made a comment. I'll just get you all to work of breathing. What's the likelihood? How much is work of breathing likely to be reduced in somebody under using this technique? I mean, is it small changes? Is it big changes over the course of a night?
The sneaky answer is to say we ought to measure it, but I have a nagging feeling that this is where I came in, or at least this is where my old boss came in, because long before I was a physiologist, he was measuring work of breathing as a ventilatory response outcome. And I think a lot of this stuff is a little bit buried in the past. But I think that we should be able to improve work of breathing. We know with relatively unsophisticated ways of delivering ventilatory support to COPD patients that you can improve work of breathing. My suspicion, I don't have any data to say that, is that if you target it in the way that we now can using these modern approaches, we will get a more precise improvement in work of breathing. I think the nice thing about this idea, apart from the fact I'm keen on it, I'm a physiologist, I like this stuff. But apart from that, is it ticks this terrible jargon box which we now all live with, called precision medicine, which comes back to the old-fashioned principle of giving the right treatment for the right person in the right way. And you can do that with the aid of the sort of loop algorithm, one of which is up on the screen behind me. And most data from most fields of medicine show that when you do that, you cut down on unnecessary over-treatment as much as you do on under-treatment. I think that will translate into an improvement in work of breathing, but the proof of the pudding will be, of course, to measure it.
Other questions?
Yeah. Hello, thank you for the talks. Just like to ask if there are any current studies regarding the impact, long-term impact of CPAP treatment in COPD patients without OSA?
They're not to date.
Nope.
People have used it for fairly short periods of time. They are planned, but they have not happened yet.
Yeah.
Let me ask one other question of either one of you. Right now, the way people are ventilating COPD patients. They went to the high intensity and they got these huge pressure support levels. They've come back a little bit from that, but there's still probably 15 to 20 centimeters of water pressure support used. How much pressure support do you think is going to be necessary if you optimize the EPAP to get rid of the expiratory flow limitation? Is that number likely to come down the pressure support value?
I'll have a go at tackling that, and the answer is yes. I think that was the answer you were wanting. But it is yes, and the reason is sort of self-evident. If you think about what we're doing, effectively, with the aid of a device like this automated ventilated system, we can overcome that downward step on the waterfall. We can eliminate the part of flow limitations in most of the pathways to the peripheral lung. And COPD is, of course, a very heterogeneous disease. Now, one of the problems with just slamming people on high levels of pressure support is you will do that. The sorts of pressures, inspiratory pressures that people have done will have expanded the airways to such a degree that this will happen, particularly when it's combined with very high levels of EPAP. And that therefore means that you will have that pressure transmitted to the chest wall, to the lung parenchyma, and you will change the operating lung volume, and you will increase the work of breathing because you've done that. It's not an easy trade-off, and lots of people have found that this is the case. A lot of us were very optimistic in the early days of mechanical ventilation in COPD. All we had to do was give people enough pressure, enough EPAP initially to overcome that work of breathing problem, and it would all be sorted. Well, it wasn't, which was very disillusioning for people like me. Now we've gone to the stage of giving these very high pressure levels, but the downside of it is that behaviourally it's hard for the patient to cope with. Yes, if you keep them in hospital 5 days, you can train them to adapt to it, and with a lot of support you can keep them at that level, but it's a very, very big effort to put in for the reward that's obtained. So my prediction, and it's nothing more than a prediction, and as has been said before, prediction is very difficult, particularly about the future, but my prediction would be that there will be lower levels of pressure support required because mechanically you're not going to need such. I can't see why you would need to give such high levels of pressure support once you've overcome the problems of expiratory flow resistance.
Thank you very much for your presentation. Gerardo Ferrero from Argentina. Based upon you have explained, Professor, the algorithm is just designed for being used with the AVAPS mode, or likewise we have nowadays with the AVAPS without an EPAP, or you might be used the EFL just with a fixed IPAP.
It'll be available both ways. You can do it either way you want.
Okay, thank you.
Do you have a preference?
For sure. Well, actually, I mean, based upon the physiopathology on the patient, I understand that probably they're using with a preset volume like AVAPS could be more wisely to be adapted, but it depends on the patient.
Are there any other questions? Well, I'd like to thank our speakers and thank the audience very much. We're excited about this.